All right, class, let's get into one of the most important topics you'll face as a nurse: fluid and electrolyte balance. Now, I know that might not sound as dramatic as code blue or neuroemergency, but hear me out. Every single patient you will care for, in every setting, has a fluid and electrolyte status that you are either maintaining or correcting. That includes your critical care patients, your med-surg assignments, your long-term care residents, and even your PEDS cases. The reason this matters is simple. Every process in the body depends on having the right type and amount of fluid in the right place. Shift that balance, and the body will let you know, sometimes subtly and sometimes like a 5-alarm fire. The big picture: homeostasis. We use the word homeostasis to describe the body's constant balancing act, keeping our internal environment stable. Even small changes in water, sodium, potassium, or pH can throw everything off. And here's a tip you'll see on exams. Almost every fluid or electrolyte disturbance has more than one cause and more than one effect. So we don't just memorize signs and symptoms, we learn the why so we can think through the problem when it shows up, where the fluid lives. About 60% of an adult's body weight is fluid. That includes both water and electrolytes. We divide that fluid into two major compartments. First, the intracellular fluid. That's all the fluid inside the cells. It makes up about 2/3 of all body fluid and is where most of the body's potassium lives. Second, the extracellular fluid. This is the fluid outside the cells. It makes up the other 1/3 of total body fluid and breaks down further into 3 areas. The intravascular space, which is your plasma and the blood vessels. The interstitial space, which is the fluid between the cells, including lymph. And the transcellular space, which includes specialty areas like cerebrospinal fluid, pleural fluid, pericardial fluid, synovial fluid, intraocular fluid, digestive secretions, and even sweat. Now, the body is constantly moving fluid between these compartments, and cell membranes are semi-permeable, meaning they choose what moves in and out. When fluid goes missing, third spacing. Sometimes fluid doesn't actually leave the body, but it becomes unavailable for circulation because it shifts into spaces where it's not useful, places like the peritoneal cavity or the pleural space. We call this third spacing. An early sign of third spacing is a drop in urine output, even when intake is fine. The kidneys think there's a low circulating volume and start conserving. You might also see an increased heart rate, low blood pressure, low central venous pressure, edema, and an increase in body weight. Eventually, that fluid can move back into circulation, but until it does, the patient is effectively volume depleted. Electrolytes. The body's electrical current electrolytes are charged particles that keep everything from nerve conduction to muscle contraction running. Cations are positively charged: sodium, potassium, calcium, magnesium, hydrogen. Anions are negatively charged: chloride, bicarbonate, phosphate, sulfate, and negatively charged proteins. The way they're distributed is important. Inside the cells, potassium is high and sodium is low. Outside the cells, sodium is high and potassium is low. This difference is essential for life. Sodium is the main extracellular cation, and it controls water balance. Remember, water follows sodium. If you retain sodium, you retain water. Lose sodium, and you lose water. Potassium is the main intracellular cation, and even small changes in extracellular potassium can change cardiac rhythm. Large releases of potassium, such as from cell damage, can lead to cardiac arrest. Normal electrolyte concentrations. In the extracellular fluid, sodium runs between 135 and 145 milliequivalents per liter, potassium between 3.5 and 5, chloride between 98 and 106, bicarbonate between 24 and 31, calcium between 8.5 and 10.5 milligrams per deciliter, phosphate between 2.5 and 4.5, and magnesium between 1.8 and 2.6. In the intracellular fluid, sodium is around 10 to 14 milliequivalents per liter. Potassium is 140 to 150. Chloride is 3 to 4. Bicarbonate is 7 to 10. Calcium is less than 1. And magnesium is about 40 milliequivalents per kilogram of body weight. How fluid moves osmosis is the movement of water toward the saltier side. Osmolarity is the concentration per kilogram of solvent, and osmolarity is the concentration per liter of solution. In clinical practice, we use osmolarity more often. Starling's forces explain capillary fluid movement. Hydrostatic pressure pushes fluid out, Osmotic pressure pulls it back in, and oncotic pressure from proteins like albumin keeps fluid in the blood vessels. E-Phe fluid types by tonicity. Isotonic fluids, such as normal saline or lactated ringers, don't cause fluid shifts between compartments. They just expand plasma volume. Hypotonic fluids like half-normal saline move water into the cells, useful for dehydration, but risky if the patient already has cerebral edema. Hypertonic fluids like 3% saline or mannitol pull water out of the cells, useful for severe edema, including cerebral edema. The sodium-potassium pump, picture it like a security guard at a club. 3 sodium ions go out for every 2 potassium ions allowed in. This is powered by sodium-potassium ATPase and is essential for nerve impulse transmission and muscle contraction. Fluid gains and losses. We gain fluid primarily through eating and drinking. We lose it through the kidneys, 1 to 2 liters a day, or about 1 milliliter per kilogram per hour. We lose it through the skin, about 500 milliliters daily from sweat and insensible loss. We lose about 300 milliliters a day from the lungs through water vapor, and 100 to 200 milliliters through the GI tract, more if there's diarrhea or fistulas. Laboratory indicators of fluid status. Serum osmolarity runs between 275 and 290. Urine osmolarity is the best measure of urine concentration. Specific gravity ranges from 1.05 to 1.030, but is less reliable than osmolarity. BUN runs from 10 to 20 and rises with dehydration. Creatinine is 0.7 to 1.4 and is the best indicator of kidney function. Hematocrit rises with dehydration and falls with overhydration or anemia. Urine sodium changes with intake and fluid status. Homeostatic mechanisms. The kidneys filter 180 liters of plasma per day, regulating volume, electrolytes, and pH while excreting wastes. The heart and blood vessels maintain the pressure needed for kidney perfusion. The lungs regulate acid-base balance through carbon dioxide excretion and lose water through exhalation. The pituitary gland stores and releases antidiuretic hormone to conserve water. The adrenal glands produce aldosterone, which holds sodium and water while excreting potassium. Excess cortisol can also retain fluid. The parathyroid glands regulate calcium and phosphate through parathyroid hormone. Baroreceptors sense changes in pressure and volume and trigger both the sympathetic nervous system and the renin-angiotensin-aldosterone system. RACE, ADH, and natriuretic peptides. When perfusion is low, the kidneys release renin, which converts angiotensin 1 into angiotensin 2. Angiotensin 2 is a potent vasoconstrictor and triggers aldosterone, leading to sodium and water retention and potassium excretion. Antidiuretic hormone is released when osmolality increases or volume decreases, increasing water reabsorption in the kidneys. Natriuretic peptides. Atrial natriuretic peptide, brain natriuretic peptide, and NT-proBNP promote sodium and water excretion, cause vasodilation, and counteract the renin-angiotensin-aldosterone system. Special considerations for older adults. With aging, we see less muscle mass, less water, and more fat. Cardiac, renal, and respiratory function decrease, and the thirst mechanism becomes less sensitive. That means older adults may not feel thirsty even when they are dehydrated. They're more prone to fluid overload, and their skin becomes thinner, less elastic, and more fragile. Dehydration is common because of decreased kidney mass, decreased glomerular filtration rate, decreased renal blood flow, decreased ability to concentrate urine, decreased sodium conservation, decreased potassium excretion, and decreased total body water. Even small changes that a younger adult might tolerate can cause significant problems in older adults. Final takeaway. As a nurse, your job is not just to look at lab values. It's to understand where the fluid is, what's moving it, and how quickly you can recognize a shift before it becomes a crisis. That's where your assessment skills, your critical thinking, and your understanding of the why will protect your patients.